Welcome back, everyone, to Part 5 of our Breast Surgery Coding Masterclass. I am absolutely thrilled to have you here for this explainer. If you joined us for Part 4, you might remember we spent some time decoding the intricacies of breast localization devices. Well, today, we're taking a massive step forward in the clinical journey, transitioning straight from localization right into diagnostic tissue sampling. We're tackling breast biopsies. This is an absolutely foundational area for medical coders, billing analysts, and documentation specialists, and I promise you, mastering it is a total game changer for how you approach your operative charts.
But before we even peek at a single CPT code, I've got a central auditing question for you to chew on. What must every coder look for when they first open a biopsy operative note? I mean, is it the size of the needle, the amount of tissue removed, or maybe the number of incisions? Identifying the precise elements that actually drive our code selection is exactly the puzzle we're going to solve today.
Okay, let's dive into this. Here is our quick roadmap for today's masterclass. We'll start with the diagnostic biopsy objective, move into non-guided and open approaches, then hit the image-guided biopsy master grid. After that, we'll navigate some unbundling traps and audit rules, tackle a live operative chart walkthrough, and finally finish up with our episode wrap-up and teaser.
Section 1. The diagnostic biopsy objective. Let's define the goal.
You know, every single procedure we code starts with clinical intent. The primary goal of a breast biopsy is quite literal. It's to allow a pathologist to definitively examine suspicious tissue under a microscope. They need to differentiate benign, harmless tissue from something far more serious, like atypia, an in situ neoplasm, or an invasive carcinoma. Clinically speaking, a sterile needle is placed into the region of the abnormality, and multiple little cores of tissue are extracted out. Understanding this physical extraction is absolutely key to recognizing when a biopsy has genuinely occurred in your documentation.
Section 2. Non-guided and open baseline approaches.
Okay, there is a very clear binary difference between our two foundational baseline biopsy methods here. On one hand, we've got CPT 19100. This is your code for a percutaneous needle core biopsy that specifically does not use any imaging guidance. It's a separate procedure where the physician relies entirely on palpation or visual landmarks. Now, on the other hand, we have CPT 19101. This is a completely different ballgame. It's an open, incisional surgical biopsy. We're talking scalpel and direct surgical exploration to physically extract the tissue.
And this brings us to an absolutely crucial rule you've got to remember for these specific baseline codes. You must append modifier -50 to both 19100 and 19101 if the biopsy is performed bilaterally, meaning on both breasts. I'm hitting this point hard right now because, as you're about to see, these foundational non-guided and open codes behave very, very differently than our modern image-guided codes when it comes to laterality.
Section 3. The image-guided biopsy master grid.
Now, what's really interesting about this next concept is how highly coordinated it is. What we're looking at here is a physician performing a percutaneous core biopsy under active ultrasound guidance. One hand is expertly manipulating the ultrasound transducer, watching the lesion in real time on a monitor, while the other hand advances a specialized biopsy device precisely into that target tissue. It's a highly technical, technology-driven procedure.
And because this clinical process is so wonderfully unified, the coding system treats it exactly the same way. Enter what I like to call the golden all-inclusive rule for CPT codes 19081 through 19086. When you use these image-guided percutaneous biopsy codes, they inherently include three specific elements: the needle biopsy extraction itself, the specific imaging guidance used, and the placement of any localization clip or metallic pellet. All three of those clinical actions equal exactly one primary code. No exceptions. You simply cannot break them apart.
Let's walk through this master grid logically, because it's super systematic once you see the pattern. The entire hierarchy of these image-guided codes is based strictly on the modality of the imaging used. If the physician uses stereotactic guidance, your initial lesion is 19081, and any additional lesions biopsied using that exact same guidance get the add-on code 19082. For ultrasound guidance, like we just talked about, it's 1903 for the first lesion and the add-on 19084 for subsequent ones. Finally, for MRI guidance, you start with 19085 and use add-on 19086 for any additional lesions. Pretty clean, right?
Section 4. Unbundling traps and audit rules.
So the crucial point here is keeping your charts squeaky clean and avoiding compliance errors. First rule of thumb:
Never, ever separately report a clip placement or radiological guidance if you're using the 19081 to 19086 series. Remember our golden rule? They are totally bundled. Second, and honestly, this trips up a ton of people. If a surgeon takes 4, 5, or even 10 core samples from one single lesion, that still equals just one single unit of the CPT code. We code by the number of lesions, not the number of cores extracted. And finally, for bilateral or multiple lesions using the same guidance, you use the add-on codes for the additional lesions, even if that second lesion is sitting over on the opposite breast. Do not use a 50 modifier with these add-on codes.
Section 5. Live Operative Chart Walkthrough.
All right, let's put this into practice with a real-world puzzle drawn right from our source training. The patient has a 2-centimeter lesion located at the 2 o'clock position of the right breast. The operative note states a 14-gauge needle was placed under sterile ultrasound guidance, 4 core samples were obtained, and a non-ferromagnetic clip was placed right at the biopsy site. So, how do we code this?
Let's move to the logic and see how this builds step by step. Step 1. Identify the guidance. The note clearly says ultrasound guidance. That instantly points us to the 19083 and 19084 family. Step 2. Quantify lesions versus cores. We know there's only one lesion mentioned, even though 4 cores were taken. So we only need our primary code, not the add-on. Step 3. Check for bundled extras. Yes, a clip was placed, but thanks to our golden rule, we know that's securely bundled into the primary code and not reported separately. Step 4. Our final code. We land perfectly on 19083 and we append the RT modifier to indicate the right breast. Boom! Perfectly audited.
Section 6. Episode Wrap-Up and Teaser. Before you go tackle your next shift, here is a rapid-fire mental cheat sheet for your audits. 1. Determine immediately if the approach was open or percutaneous. 2. If percutaneous, was imaging guidance used? 3. If imaging was used, rigorously apply that golden all-inclusive rule. Do not unbundle the clip or the guidance. And 4. Literally the biggest takeaway. Always count the lesions, not the cores.
You have officially conquered breast biopsies. But the clinical journey doesn't stop there. What happens when the physician decides to outright destroy the tissue rather than just sample it? Well, next time, in part 6 of our masterclass, we're exploring breast lesion ablation techniques. We're going to dive deep into how to accurately code for minimally invasive energy destruction, like cryoablation, laser ablation, and microwave thermotherapy. It is a wildly fascinating frontier in breast surgery coding, and you definitely won't want to miss it.
Before we go, ask yourself, will you catch the next unbundling trap before it costs your practice? Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in part 6.